Bismillahirrahmanirrahim. Today, topic of my lecture for you people is intussusception and volvolus. Now, the learning objective of this lecture is that at the end of this lecture, the student should be able to define what is intussusception and what is volvolus, and then what are the clinical features of both these conditions, what are the investigations which are done to diagnose intussusception and volvolus, and what is how to treat intussusception and volvolus. So firstly, these are two conditions basically which are the causes of acute intestinal obstruction. So we start with the intussusception. Now what is intussusception? If we define it, this is basically this occurs when one portion of the gut invaginates into an immediately adjacent segment of the intestine. Almost invariably, it is the proximal into the distal invagination. So, by definition, intussusception occurs when one portion of the gut invaginates into an immediately adjacent segment of the intestine. Here you can see in the photograph that this is proximal gut which is invaginating into the distal segment of the eye. So this is intussusception by definition. This condition is encountered most commonly in children with a peak incidence between 5 to 10 months of age. That means this is most common in infants below 1 year. Male to female ratio is approximately 3 to 2. Now, it is intussusception may be anatomically defined according to the site and extent of the invagination. And what is meant by that in the coming slide, I will explain to them. In most children, the intussusception is ileocolic. This is by anatomical definition by one variety, which is the most common, is ileocolic. That means ileum is invaginating into the colon. In children, the most common variety is ileocolic, but in adults, on the other hand, colocolic intussusception is more common. Then if we talk about the types here, it means it may be antegrade or it can be retrograde. Antegrade, that means the proximal intestine invaginating into the distal intestine, it is called antegrade type of intussusception. And retrograde, which is it's a rare, or one example of this retrograde is the jejunal-gastric intussusception in gastrojejunostomy stoma. So when gastrojejunostomy has been done, jejunum then invaginates into the stomach through this gastrojejunostomy communication stoma, you can say that. So this is one variety which is rare, retrograde. It can be ileocolic, which is most common type. 70% of the cases they are ileocolic. Then colocolic, ileocolic. There are a number of ileocolic. So we can anatomical by the extent and anatomical varieties. In the next slide, I will explain you what is meant by this. Here you can see the type of intussusception in children. So depending upon the extent and the site of invagination, here you can see the commonest is ileocolic, which is 77%. Then 12% cases they are ileocolic. After that, you can see ileo-ileal intussusception. About that makes about 5% of the cases. Colocolic, it is about 2%, and these are the types in children. Multiple sites, 1% cases. Retrograde, as I told you, about 0.2%, and others about 2.8. So if we see what are the types of intussusception in children anatomically, the commonest is ileocolic. Now, etiologically, the condition is encountered most commonly in children, as I told you, with a peak incidence between 5 to 10 months of age, infants. About 90% of the cases are idiopathic, but an associated upper respiratory tract infections or gastroenteritis may precede the condition. It is believed that hyperplasia of the Peyer's patches. No, when we are talking about the intussusception in children, which is idiopathic, where that makes about 90% of the cases, and it is in the terminal ileum, in the terminal 50 centimeter of the ileum. So, regarding that, as we said, it is usually idiopathic, but associated upper respiratory tract infection, that I'm repeating it, and gastroenteritis may precede this condition. Now, it is believed that hyperplasia of the Peyer's patches in the terminal ileum may be an initiating event. Weaning in this age group, loss of passively acquired maternal immunity, then common viral pathogens have all been implicated in the pathogenesis of intussusception in infancy. So, although we call it idiopathic, but we have count number of factors which may be associated with idiopathic intussusception in infants. Now, the second variety, which may be there, children with intussusception associated with a pathological lead point. Lead point, I will explain in a next slide what is lead point basically. The point from where the invagination starts and some cause is there. Now, leading point in children may be Meckel's diverticulum, polyp, duplication, Henoch-Schönlein purpura, or appendix. These are usually present older than those with idiopathic disease. So, the children with more than 1 year of age, they may have a leading point, and as I've enumerated what are the different leading point in this intussusception may be there. In adults, if we see, usually the intussusception is invariably associated with the lead point, which is usually a polyp, like Peutz-Jeghers syndrome हो सकता है, then a mucosal lipoma or other tumors like maybe carcinomas with papillary projections, submucosal lipoma. So these are number of conditions which will form a leading point for the formation of intussusception in adults. Now, spontaneous intussusception in adults is very uncommon without leading point. It is very uncommon, but when very uncommonly in cases of celiac disease and then cases of scleroderma, intussusception even in adults without a leading point can occur. Here you can see intussusception without a leading point. Here you can see this is proximal gut and this is the distal gut. Here you can see this is proximal gut is invaginating into the distal gut, but there is no leading point here. Only you can see lymphoid hyperplasia here, which I narrated in infants. Hyperplasia of the Peyer's patches may be a initiating cause. So with the leading point, here you can see on the photograph diagram, here this is the leading point. So which can be a submucosal lipoma, it can be a polyp, maybe a case of Peutz-Jeghers syndrome presenting with the intussusception. These are the cross sections. You can see cross sections of the intussusception without a leading point. This is cross section. Here it is the cross section with the leading point. So this is the leading point is the cause of intussusception in the adults. Usually when we usually say that when an adult person presents with the intussusception, we usually assume that probably there is a leading point, some underlying pathology is there, and we are prepared for that. Now, as far as the pathology of intussusception is concerned, intussusception is composed of three layers. The entering or the inner tube, intussusceptum. This is the entering lobe. You can see entering lobe into the, this is proximal, which is entering into the distal lobe. So this is the inner tube. Then returning or middle tube. This is the returning layer. You see, this is returning. And then the outer sheath or outer tube, which is also called intussuscipiens. This is the outer tube. So as far as pathology is concerned, intussusception has three layers, three parts. Here you can see this is the apex of the intussusception. So the part that advances is the apex. This is apex, which advances into the distal, and the mass is the intussusception. This is part is mass. Whole part you can see this is mass formation. And then the neck. This point is the neck of the intussusception. So junction and the neck is the junction of the entering layer with the mass. This area. This is the neck of the intussusception. Intussusception may be anatomically defined, which I said in previous slide, according to the site, extent of the invasion, and number of types we narrated in that slide. In most children, the intussusception is ileocholic. Again, it's a repetition. This is the commonest cause in commonest variety in the children. In adults, it is the colic intussusception, which is more common. Now, the degree of ischemia is dependent on the tightness of the invagination, and which is usually greatest as it passes through the ileocecal valve. That is the constriction point, when it passes through the ileocecal valve. So that may lead to ischemia of the gut. Now, clinical feature, how these patients they present these cases of intussusception, they present. Common in males, as I told you earlier, ratio is 3 to 2. The commonest age is the infants between 6 to 9 months, but can also occur at a later age group at children, later age group children. Common in spring and winter, coinciding with the gastroenteritis and respiratory infections in respective periods. In these periods, there are cases in children of respiratory tract infection, gastroenteritis occur. And while talking about the idiopathic type of intussusception in infants, we associated these factors with the occurrence of the idiopathic intussusception. Now, this is the the commonest cause of intestinal obstruction in infancy is this idiopathic intussusception. The classical presentation of intussusception is with episodes of screaming and drying up of the legs in a previously well male infant. So during the attack, the child appears pale. It's a colicky pain which occurs basically. So repeated episodes of screaming and then drying, the infant draws up the legs, which is the patient who was previously well. So it indicates it's a colicky pain. Intestinal colic is occurring in the child. So during attacks, the child appears pale when there is colic. This is one of the feature of the colic, that patient becomes pale. So similarly in infants, when there is a colic attack, then the child will be pale. But between episodes, he may be listless. So a colicky pain is one pain. When we define this pain, it is a which is sudden in onset. It's a waxing and waning pain. It comes and goes. It is always a severe pain. Patient is pale when there is attack of colic and may be associated with vomiting and sweating. It's a very severe pain. It's not mild. You can't say a colic is a mild pain. It's always severe. So during attacks, the child appears pale while pain is occurring, colic is occurring. But between the episodes, when there is no pain, then the child becomes listless. Vomiting attacks, these attacks may last for a few minutes and recur repeatedly. Vomiting may or may not occur at the outset, but becomes conspicuous and bile stained with time. Initially, the passage of stool may be normal, but whereas later on, blood and mucus are evacuated, and typically this is called red currant jelly stool. So, in infant with intussusception, the infant passes red currant jelly stools. This is an infant. You can see red currant jelly stool. This is the appearance of the stool with idiopathic intussusception in infants. On examination. So on examination, whenever possible, examination should be undertaken between episodes of colic without disturbing the child. Classically, the abdomen is not initially distended. A lump that hardens on palpation may be discerned, may be palpable, but this is present in only 60% of the cases. So, in 60% of the cases, a lump is palpable, and when you palpate, this lump becomes hardened. There is change, it becomes hard. There may be an associated feeling of emptiness in the right iliac fossa. The right iliac fossa, when you will palpate in this infant, it seems to be empty. This is called sign of dance. This is sign of dance. This you can say that. In these infants, when rectal examination is done, blood stained mucus will be seen on your finger stall. Sometimes what happens when there is an extensive ileocolic or colocolic intussusception, means when it is very long one, in those cases apex can be palpable with digital examination, and even sometimes what happens, it protrudes through the anus. So very extensive, long intussusception. Maybe you can palpate with your finger, little finger, on digital examination, or it may protrude outside the anus. Unrelieved, if it goes unrelieved, progressive dehydration, then abdominal distension from small bowel obstruction will occur. And this will be followed by peritonitis, which is due to ischemia. When the gut becomes ischemic, so the late features in intussusception will be features of intestinal obstruction, and later on, if the gut becomes ischemic or there is perforation, peritonitis occurs in these patients. Very rarely, natural cure may occur as a result of sloughing of the intussusception, the part which is within which has invaginated from the neck to the apex may slough, and the natural continuity is, but it occurs very rarely. Here you can see in the photograph, this is sausage shaped mass which you can palpate in the umbilical area with the concavity towards the umbilicus. Now, if we talk about the then we can say differential diagnosis of acute intussusception. So, among differential diagnosis in intussusception in infants, acute gastroenteritis, enoxational purpura, rectal prolapse. These are the conditions which are sometimes taken as differential diagnosis of the intussusception. Obviously, when you will suspect that it's a differential diagnosis with rectal prolapse when the intussusception is extensive, protruding through the anus. So in that case only, but which is very rare. And in cases of henoch-Schönlein purpura, which is associated with a characteristic rash and abdominal pain, and one complication which can occur in henoch-Schönlein purpura is intussusception, that you should keep in mind. And these are among the differential diagnosis of the intussusception in children. So, if we talk about the investigation which are done for intussusception, a plain abdominal field X-ray usually reveals evidence of a small or large bowel obstruction with an absent cecal gas shadow. So, if you do a plain X-ray abdomen in these patients, there will be evidence of small or large bowel obstruction, and there will be absent cecal gas shadow. Normally, when we do a plain X-ray abdomen, we can see a gas shadow in the right iliac fossa, and we usually call this is gas in the cecum. Then it will be absent in cases of ileocolic intussusception. A soft tissue opacity is often visible even in plain X-ray in children. A barium enema is another investigation, contrast study, which can be done for the diagnosis of intussusception, and it will show a class sign. So, barium enema, typically it shows class sign or a coiled spring pincer end. So, barium enema, your typical finding is a class sign, which I later on show you X-ray of barium enema, and you can see on that. Ultrasonography. Abdominal ultrasound has a high diagnostic sensitivity in children, demonstrating the typical donut appearance of concentric rings in transverse section. So, transverse section in the ultrasound, you can see there are transverse concentric rings on ultrasonography, and these are called donut appearance. So this finding is on abdominal ultrasonography, and it is also useful to check blood supply of the bowel on Doppler study. About the plain X-ray, I have already told you. In intestine, other than the on X-ray, you can also see multiple air fluid levels because there is intestinal obstruction. Now, these are few X-rays you can see. This is barium enema, and it's a class sign. Here you can see it's a class sign. It's a barium enema. Yes, contrast is visible. This is colon. Heart stations are visible. So it's a class sign. Plain X-ray abdomen, a meniscus sign, a mass which you examined on palpation. It was a sausage-shaped mass. So here you can see when it is invagination inside, here is the gas, but here is the soft tissue, and this is called meniscus sign, which is even visible on plain X-ray if carefully it is sought. Then ultrasound abdomen, here you can see this is ultrasonography, transverse sections of the gut, and this is donut appearance. CT scan with contrast, CT scan abdomen with contrast, you can see it is called target sign. It's a target sign, circular, and in the middle is a target you can hide. So it is the similar is it's a target sign. Now, if we come to the treatment of intussusception, now what is the treatment? Obviously, in the infant with ileocolic intussusception, initially we have to resuscitate, as all the cases of intestinal obstruction. Obviously, the initial part of the treatment that we have to resuscitate these patients. And what is resuscitation? Resuscitation with intravenous fluids, broad spectrum antibiotics, nasogastric suction, passing a nasogastric tube and emptying the stomach. Then a non-operative treatment, non-operative reduction can be attempted. So, what is non-operative reduction? This can be attempted using an air or barium enema. So, this is sometimes successful in 70% of the cases of idiopathic intussusception in infants. So successful reduction can only be accepted if there is a free reflux of air or barium into the small bowel, together with the resolution of symptoms and signs in the patient. So we only accept that non-operative treatment is successful when there is a free passage of air through the ileocecal valve into the small gut, or barium is passed from the ileocecal valve into the small gut. That means it is successful and obstruction is relieved. So it is successful in about 70% of cases. But a non-operative reduction is contraindicated if there are signs of peritonitis or perforation. There is a known pathological lead, or when there is a known pathological lead point, even then a non-operative reduction is contraindicated. Or in the presence of profound shock. Obviously, shock, hypovolemia in these patients will only occur when there is a peritonitis. So, contraindication of non-operative treatment, which is reduction using air and barium enema, and it is about successful in about 70% of the cases. But per se, you will not do this non-operative treatment if there are signs of peritonitis or perforation, there is known pathological lead point, or patient is in shock. That means when the shock only occurs obviously when this is a case of peritonitis. Now, recurrent intussusception, when we do non-operative reduction, so in up to 10% of the patient after non-operative treatment, there are chances of recurrent intussusception. So the 10% cases after non-operative reduction will have recurrent intussusception. This again effect must be kept in mind. So surgery is required when radiological reduction has failed or it is contraindicated. So indications of surgery क्या है? Failed radiological reduction, so non-operative treatment when it is failed, or there are contraindication for non-radiological or non-operative reduction, which we already know. We have enumerated those contraindications. So what is done in surgery? After resuscitation, it transfers right side abdominal incision, provide good access into the abdomen. Reduction is achieved by gently compressing the most distal part of the intussusception towards its origin, towards its proximally. So when we do reduction, when we see on laparotomy that it is gut is viable, so we try to compress distally to reduce the intussusception in proximally. We are not going to pull the proximal gut from the distal. So what is the idea? After reduction is achieved by gently compressing the most distal part of the intussusception towards its origin, making sure not to pull it. So pulling the proximal invaginating part of the gut is contraindicated. The last part of the reduction is the most difficult. So when we are doing reduction, when the gut is viable and you are reducing the intussusception, it is the last part of the intussusception which is difficult to reduce to. The viability of the whole bowel should be checked carefully. Obviously, when we are doing a reduction, this is very important that the gut is viable. No, when it is not possible, or it cannot be reduced, or there is a lead point, or when gut is ischemic, there is gangrene of the gut, obviously the choice is resection and primary anastomosis. So in irreducible intussusception, or one complicated by ischemia, or when there is a pathological lead point, we know that in this particular patient there is a lead point. So in those cases, what is the choice of surgery? That we have to resect the gut and a primary anastomosis is done. Now, what is the take-home message? What is the summary at the end of this intussusception? Intussusception, most common in children. You must remember that. Adult cases are secondary to intestinal pathology like polyp, Meckel's diverticulum. Ileocolic is the commonest variety of the intussusception. It can lead to an ischemic segment. So ischemia can occur with intussusception. Radiological reduction is indicated in most pediatric cases. It is successful, as I told you, in 70% of the cases. Adults which are usually having a lead point, they require surgery. Even in children, surgery is required, but majority cases they are reduced by radiological, by barium enema or passage of gas. So adults, surgery usually have to do because there is a lead point, and idiopathic it is radiological reduction which is this. So this is the take home message for you after this lecture on intussusception. Now if you come to the volvulus, what is volvulus? Volvulus, which is a Latin verb, vary, to twist, refers to the axial rotation and of an organ around its pedicle. So, how we can define volvulus? A volvulus is a twisting or axial rotation of a portion of the bowel about its mesentery. Here you can see in this photograph. This is a loop of bowel which is twisted here. So what is volvulus? It's a twisting or axial rotation of a portion of bowel. It's a part of, here you can see it's a colon bowel about its mesentery. Here it is the mesentery of the sigmoid colon where it has rotated. Now, what happens? Rotation causes obstruction to the lumen. So when there is a rotation of about 180 degrees torsion, it is only the lumen which is obstructed. And if it is tight enough, then it can also lead to vascular occlusion in the mesentery. So when there is a torsion of more than 180 up to 360 degree torsion, then vascular occlusion occurs in the mesentery. Now what happens? Bacterial fermentation, which occurs in the loop, that adds to the distension of that loop, and it increases intraluminal pressure. And when the pressure within the loop is increased, it impairs the capillary perfusion of the gut. It's a vicious cycle that which starts. Mesenteric vein, this is a vicious cycle. When this occurs, then there is a progression in the distension. The neck weak structure obviously veins, the mesenteric veins, they become obstructed as a result of the mechanical twisting as well as increased pressure within the loop. And then thrombosis occurs in the veins, and this ultimately contribute to the ischemia of the gut. Obviously, ultimately, due to torsion, arteries they are also occluded. So ischemia, the gangrene of the gut, occurs in these patients. Now, what are the different types of volvulus? Volvulus can be primary or it can be secondary. Now, what is primary volvulus? When we say this is a primary volvulus, the primary form occurs secondary to congenital malrotation of the gut. So, in primary volvulus, usually there is some congenital type of anomaly, like congenital malrotation of the gut, abnormal mesenteric attachments, or there are congenital bands. So when these are the cause of volvulus, we say there is a primary volvulus. Congenital anomalies are associated. One example includes the volvulus neonatorum. Then cecal volvulus. How cecal volvulus is a primary volvulus? There is a congenitally anomaly, we call it floating volvulus. Cecum is usually a retroperitoneal structure, it's a fixed structure. Sometimes it has a mesentery. So it is called floating cecum. So these are the cases where volvulus of the cecum can occur. Similarly, sigmoid volvulus, when there is a long mesentery, narrow attachment of the mesentery, these are basically congenital anomalies regarding the sigmoid colon. When long mesentery is there, then attachment of the mesocolon of the sigmoid colon is very small. So these are the cases where primary volvulus of the large cat can occur. What is secondary volvulus? A secondary volvulus, which is more common variety. More commonly, it is the secondary volvulus which occurs. It is due to rotation of a segment of the bowel around an acquired DNR stoma. So, secondary volvulus by definition, when the rotation of segment of the bowel occurs around an acquired adhesion, or sometimes the stoma is formed through the abdominal wall, and around that stoma rotation can occur. So it is called secondary volvulus. That these factors you must keep in mind. Now, what are the different types of volvulus? Presentation, depending upon the presentation, another way to group them is that it's a fulminant. Presentation can be classified as fulminant, when there is a sudden severe pain, early vomiting, rapidly deteriorating clinical course, and then there are cases of volvulus which are indolent, insidious onset, slow progression, progressive course, less pain, less late vomiting. So these are the features. So now if we talk about the types, so one way is to group and like that, also classified according to location, as the type of volvulus may be small bowel volvulus, cecal volvulus, which make about 20 to 40% of the cases. Then another type of volvulus is the sigmoid volvulus, which makes about 60 to 80% of the cases of volvulus. And another variety is compound volvulus. Now, volvulus neonatum. This occurs secondary to intestinal malrotation in neonates, and it is potentially lethal fatal condition. It's a potentially catastrophic condition. That must be volvulus neonatum, and it is the intestinal malrotation which leads to this volvulus neonatum. Volvulus of the small intestine. Again, it may be primary or it may be secondary in variety type. Small intestinal volvulus can be primary, it can be secondary, as I enumerated the factors which lead to primary or secondary volvuli. It usually occurs in the lower ileum, volvulus of the small intestine. So the distal part of the ileum which is involved in the volvulus of the small intestine. It may occur spontaneously in African races, particularly following the consumption of a large volume of vegetable material. Whereas in the West, it usually is secondary to adhesions passing to the parietal abdominal, while parietes are female pelvic organs. So adhesion with those organs to the parietal wall, parietal peritoneum, are the female pelvic organs that leads to the volvulus formation in cases in the West. Now, if we come to the cecal volvulus, it may occur as a part of volvulus neonatum when that part is also involved. It is basically a malrotation of the small gut, but maybe a cecum is also involved, or it can be, it is the rotation in the cecal volvulus. As I told you previously, see, one of the causes among the primary variety of cecal volvulus is a floating congenital anomaly, floating cecum that leads to cecal volvulus. The rotation which occurs in these patients is a clockwise twist. That means your clockwise twist occurs in when there is a floating cecum with a mesentery. It is more common in females in the 4th and 5th decades of life. Usually presents acutely with the classic features of obstruction, and later on ischemia can occur in these patients. So what is the presentation of cecal volvulus? This is one cause of intestinal obstruction. Obviously, when cecal volvulus occurs, it is the small gut, terminal small gut intestinal obstruction which occurs, and when the cecum becomes ischemic, then it will lead to peritonitis. In about 25% of the cases, examination reveals a palpable tympanic swelling in the midline or left side of the abdomen. So, distended, swollen cecum that can be palpated, and this is palpable. The loop is palpable, which is going from the right iliac fossa towards the left hypochondrium, and it is present towards the left side of the abdomen. Cecal volvulus on examination. When you percusses, obviously it is containing lot of gas, so this loop will be tympanic on percussion. So cecal valves, again I repeat, typically results in the cecum lying in the left upper quadrant. A distended cecum will be in the left upper quadrant on palpation, on percussion, and then even on X-rays, plain X-ray abdomen. Now, if you talk about the sigmoid volvulus, which is common in Eastern Europe and Africa, this is uncommon in Europe and USA. Indeed, it is the most common cause of large bowel obstruction in the indigenous black African population. Rotation nearly always occurs in the anti-clockwise. When we compare with the cecal volvulus, where rotation occurs clockwise. On the other hand, in sigmoid volvulus, rotation occurs anti-clockwise. Keep in mind that. Now the predisposing clinical features other are, and then other predisposing factors in sigmoid volvulus, they may include a high residue diet. Features, we can narrate those features. Obviously, high residue diet, that means the colon is loaded with this fecal matter. Constipation, these are the predisposing factors. In Western population, the condition is seen most often in elderly patients with chronic constipation. Comorbidities are common, and chronic psychotropic drug use is also associated with this condition. Younger patients present earlier, and the prognosis is inversely related to the duration of sleep. So, in cases of sigmoid volvulus, the prognosis. If we relate that, it is inversely a proportion to the duration of the condition, because the chances of ischemia, they are increased. So the factors which predispose to sigmoid volvulus, again we can repeat those factors. It's a long pelvic mesocolon, narrow attachment of the pelvic mesocolon, the mesocolon of the sigmoid colon, overloaded pelvic colon with fecal matter, band of adherence at the apex of the sigmoid colon. That is another factor. Here you can see that. This is a band, and it may be one cause of rotation of the sigmoid colon. Overloaded colon, fecal matter, that can lead to a volvulus formation. It's a long mesentery. Here you can see the long mesentery. Another factor is a short attachments. Mesentery, the attachment of the mesentery is very short, so there is narrow, and that leads to again sigmoid volvulus. Presentation, as I told you earlier, sigmoid volvulus ki presentation, it can be classified as one way is that it presents as a fulminant presentation. When there is a sudden onset, severe pain, early vomiting, rapidly deteriorating clinical course, because in these patients rapidly ischemia occurs with a bad prognosis. On the other hand, another presentation is indolent, and that means incident onset, slow progression, slow progressive course, less pain, and less vomiting. Another type of volvulus, here we can see this is a compound volvulus. Rare condition again. It is also known as iliosigmoid knotting. What happens in compound volvulus? The long pelvic mesocolon allows the ileum to twist around the sigmoid colon, resulting in gangrene of either or both segments of the bowel. That means maybe only the ileum is gangrenous, or only the sigmoid loop is gangrenous, or even both can be gangrenous. Ischemic can occur. Clinical feature of compound volvulus, obviously these patients, they present with acute intestinal obstruction, but because here distension is comparatively mild, both the large gut is involved as well as the small gut is involved. On plain radiography, you can see distended ileal loops in a distended sigmoid colon. So up on the X-ray, if we do a plain X-ray abdomen, we can see distended ileal loops, and along with that, there will be a distended sigmoid colon which will be visible on plain X-ray abdomen. Treatment is obviously surgery. At operation, if the gut is viable, we try to decompress. But if the gut is ischemic, gangrenous, obviously we have to do resection and anastomosis is then required. Now the clinical features of, again we can summarize the clinical features of the volvulus. What, as in other cases of intestinal obstruction, pain is one predominant feature. Initially, if it is left, initially it may be left-sided. Eventually, it becomes all over the abdomen when ischemia has occurred. As I told you, for other intestinal features, cardinal features of the intestinal obstruction, absolute constipation. There is no passage of fluid as well as stools. There is enormous distension of the abdomen starting from the left iliac fossa extending to the whole of the abdomen, which is tympanitic on percussion. In these cases of large gut obstruction, there is late vomiting, but eventually these patients also they become dehydrated. Features of peritonitis will occur late when there is ischemia, gangrene of the gut. The colon becomes gangrenous. Then all the features of peritonitis on examination you can elicit. When you palpate this patient, you can feel a tire-like feel is there on palpation of the abdomen in these patients. So you can palpate a huge loop of the large gut in these patients. Now, investigations when we do for volvulus, what are the investigation? It is if we talk about the imaging in these cases. In cecal volvulus, radiological abnormalities are identifiable in nearly all patients, but are often non-specific with cecal dilatation. 90 to 100% patient, but often. So, radiologically imaging of these patients in cecal volvulus, dilatation of the cecum is present in 98 to 100% of the cases. There will be a single air fluid level which is present in 72 to 88%, 90% of the cases. The other finding on radiology's plain X-ray of the abdomen. Small bowel dilatation may be also there because it is the cecal, ileocecal area, because cecum is obviously it is rotated, so ileum proximal to that will be dilated, and this is again visible on plain X-ray abdomen. Absence of gas in distal colon is another feature. On plain X-ray abdomen, the distal colon is having no gas, which is normally there. So about 80% of the patient. In these cases, when we have done a plain X-ray abdomen, the distal colon, distal to the cecum where rotation has occurred, is empty of any air. Another investigation which can do for these patients is barium enema. Barium enema in volvulus is very helpful. CT scan abdomen with contrast is another investigation which can help for the diagnosis of volvulus. In sigmoid volvulus, a plain radiograph shows massive colonic distension. Here you can see on this plain X-ray abdomen. This is a massive colonic distension. A loop of the sigmoid colon, you can see it is distending massively, arising from the pelvis towards going up to the diaphragm. Sometimes it is called a mega sign. single grossly distended loop of colon arising out of the pelvis and extending towards the diaphragm. This is omega sign. This is omega sign. Here you can see omega sign. Barium enema again will be helpful for sigmoid volvulus. CT scan abdomen with contrast is also done for sigmoid volvulus when you are suspecting on plain X-ray abdomen. Here are the few contrast and plain X-rays. Sigmoid volvulus, then you can see this is sigmoid volvulus, bent inner tube. Here cecal volvulus, you can see a coffee bean type appearance. This is cecal volvulus, a loop, huge loop of it. Sigmoid volvulus after barium enema. Here is the distally from the anus. Barium sulfate is given as a contrast, and the typical appearance is the bird's beak appearance. This is bird beak appearance. Now, treatment of the volvulus. Again, when we talk about the treatment of the volvulus, as in other cases of large gut obstruction or other cases of obstruction, obviously initially we have to do supportive general measures. What is meant by that? That means we have to resuscitate these patients with IV fluids. Maybe you can give what are the different fluids which are used for IV resuscitation. It is the ringer lactate or the normal saline. Then these patients, they require nasogastric decompression. We do Foley's catheterizing these patients because we want to monitor the urine output. We want to see whether our resuscitation is adequate or not. And the very sensitive criteria for that is measurement of the urine output, and that is possible with Foley's catheterization. Electrolyte replacement. Obviously, these patients are depleted of sodium, then potassium. So electrolyte, we have to replace these electrolytes, sodium and potassium. These patients, they also require analgesia and antibiotics. Why antibiotics? Because these patients have intestinal obstruction, when there is stagnation of the contents, bacteria, they flush into these contents, and when there is decompression, they can cause problems. So adequate coverage with antibiotics is. So these are the supportive general measures which are done for these patients before any intervention. At operation, now in young patients, an electives, initially, if we on examination we are sure that it's a viable colon, there are no chance of ischemia clinically, a flexible sigmoidoscope, a rigid sigmoidoscope, and insertion of a flatus tube, which allows deflation of the gut. So one method, when the gut is viable clinically, that we can do a flexible sigmoidoscopy, and even rigid sigmoidoscope can be used, and we try to insert a flatus tube, and this can lead to deflation of the gut, of that rotated gut. Now this tube, if this is successful, it should be kept there in place for about 24 hours, and a repeat X-ray should be taken to ensure that decompression has occurred. Success, as long as ischemic bowel is excluded, will resolve the acute problem. So what is the advantage of this procedure, which is a non-operative procedure with sigmoidoscopy and insertion of a flatus tube? If it is successful, that at least at that time acute condition is over. In young patient, an elective sigmoid colectomy is required. It is reasonable not to offer any further treatment following successful endoscopic decompression in the elderly, as there is high death rate but 80% at 2 year from other causes. So if you have done deflation in elderly frail patients, there's no need to do anything else. We don't try to operate on these patients because the life expectancy is less. These patients, they usually maybe die due to other causes. In elderly patients with comorbidities and recurrent episodes of volvulus, the options are resection or two-point fixation with combined endoscopic and percutaneous tube insertion, gastrostomy like tubes. They are frequently used for this purpose, and the failure results in an early laparotomy. If that fails, when this two-point fixation we are talking about, so if there is failure, then we have to do laparotomy in these patients. So now again, we go to the treatment of cecal volvulus at operation. Ischemic volvulus, if the gut is ischemic, cecum is ischemic, obviously we have need resection. But if viable, the volvulus should be reduced and unrotated, detwisted, sometimes decompression of the cecum using a needle. Now, what is meant by that? Percutaneously needle insertion in this distended loop, because it contains lot of gas, so that decompresses and it can cause decompression of the cecum using a needle. Cecopaxy and cecostomy. These are the two procedures which are done for. So recurrent volvulus after cecopaxy has been reported in up to 40%. Cecopaxy means when you fix the cecum in the right iliac fossa. And cecostomy, when we do a tube cecostomy, a tube is put in the cecum, in this distended cecum, and that will fix the cecum in the right iliac fossa with the wall. But recurrence of volvulus after cecopaxy can occur. This is up to 40% of the cases. As far as the treatment of sigmoid volvulus is concerned, I told you in sigmoid volvulus we try to reduce it with flexible sigmoidoscopy or rigid sigmoidoscopy and insertion of a flatus tube. Advantage. इसका advantage, what is the advantage? Successful deflation as long as ischemia is excluded. Provided there is no ischemia, this will resolve the acute problem. And now, what are the surgical options for that? After that, so the different operations which are required for sigmoid volvulus, they are sigmoidopexy, that is fixation of the sigmoid colon, the left iliac fossa, Paul Mikula's operation, Hartmann procedure, and then resection and primary anastomosis after an on-table lavage. Here, these are few pictures you can see. This is sigmoidoscopy with flatus tube. Here, with sigmoidoscope, a tube inserted. If it passes through this rotation, then it lead to deflation of the segment, and this cures temporarily the emergency is over. Hartmann procedure. This is another procedure which is done for volvulus of the sigmoid colon when it is gangrene, it is ischemic. So that part is resected. Hartmann procedure. What is Hartmann procedure? In this procedure, the proximal end is brought out as a colostomy and colostomy, and the distal segment which cannot be brought out is closed. It is sutured and is left inside the pelvis. This is Hartmann procedure, which is sometimes done for sigmoid volvulus when when the colon is gangrenous. This is a picture to explain the what is Paul Mikula's operation. Here again you can see the segment, the rotated segment is excised, and the two ends of the colon, they are brought through the same opening as a double barrel colostomy. Here you can see it's a double barrel colostomy, and in this procedure the wall, which is the common wall in between the two loops, that is cut inside. So this is Paul Mikula's operation. This is another method to treat the sigmoid volvulus. So that is now what is the take home message if we talk about the volvulus. Volvulus main wall, the small intestine, cecum or sigmoid colon. It may be neonatal midgut volvulus secondary to midgut malrotation, which is usually life threatening. The commonest spontaneous type in adults is sigmoid volvulus. Sigmoid volvulus can be relieved by decompression per annum. So if there is a sigmoid volvulus and there is no ischemia, it can be deflated. Attempt should be done with endoscope, colonoscope, and with the flatus tube. Surgery is required to prevent or relieve ischemia. So this is the take-home message for volvulus. I think if you have any questions, you can ask me on your WhatsApp group. I'll give you an assignment and you have to complete that assignment. Okay, thank you.